Good morning. Today I'm here to present for a CPC certification review. This video series will be broken down into a series of videos. Today we will be starting with what you can do to get the most out of this training. We'll talk about compliance. We will talk about ICD-10 CM as well as your CPT guidelines. Future videos will be then broken down by the body system type, starting with the integumentary system, and so forth. These videos are to help prepare you for your CPC exam, not to teach coding, because you already know how to do that, and that's why you are here at this point. The purpose of these videos is to not only help you prepare for your exam, but to guide you as you study and prepare for your exam whenever you have it scheduled for. So today we are going to go ahead and get started. And as always, you're always welcome to reach out after you've watched the video to schedule one-on-one time or ask questions. I am always available along with Pyle, our part-time faculty for the medical coding program as well. You can also reach out to your peer tutor, Manjula, who would also be happy to schedule time with you. All right, so let me. All right. Here we go. All right, so this is just our AMA disclaimer for the CPT being copyrighted. All right, so getting the most out of this training. So our key guideline review, we're going to talk about multiple choice processing because your exam is multiple choice. We're going to talk about time management, process of elimination, as well as marking your books. So I want to welcome you to this training. It's designed to assist you to pass the CPC. It's not designed for beginners. You should also already understand that. So we are going to take advantage of the knowledge you have and combine it with a test technique that will help you with the multiple choice process, time management, and process of elimination. You also should have received a pre-test that goes along with this CPC review that you received in a Word doc. And those questions should have been completed prior to watching these videos. Those questions are embedded throughout this review to review those answers because they are some, you may see some questions that are similar to that on your CPC exam. All right, so the process of elimination. You want to look at the answers first. Are there any key instructions or guidelines for the answers provided? Are there any parenthetical statements for the CPT codes when you look them up in your book? Typically, at first glance, you can eliminate two answers immediately. What you want to look for is a consistency within the choice of your answers. So if you see all four answers have the same ICD-10 or CPT code, that is probably going to be one of your correct codes. If there are multiple codes, then what you want to do is determine which one is not the correct code. And so if you, like, urinary codes are all going to start with an N, urinary system. Diabetes codes all start with an E. So you know if that type of diagnosis is in the question, anything that doesn't have that letter or category for that diagnosis, you know you can eliminate that. So it's that process of elimination. Time management is another key component. You have 4 hours to complete your certification exam. Even though it seems like a long time, it goes really fast. So time management is going to be your friend. On average, you do have about 2 minutes to complete each question. Everyone has unique strengths and weaknesses, and we need to remember that while one section may be harder for you, it could be easier for the person who is sitting for this same test. Don't judge your time or become obsessed with the time. You want to make sure you are just focused on answering the questions. So if you find yourself spending more time on a question than you'd like, mark that question with an asterisk on your on the electronic in the testing centers and that. They should have a flag piece in that electronic exam for you to be able to go back to that test. Go back up. So you want to mark it. When you have completed all your others, you want to then go back and do the ones you were previously unable to answer. Recommendations is you spend about an hour per, section. So you want to make sure you have 100 questions, right? And you have 4 hours. You want to make sure you're getting through 25 questions within that hour. And again, some sections may be faster for you. Some sections may take you a little bit longer. So you may find that keeping that perspective might help you than totally focusing on time. Focus on the completion of your questions. And then when it gets close to time, then you're gonna, if you have not been able to answer all the questions, you want to make sure you go through and answer questions, even if you guess. Because if you leave it blank, it will be marked wrong. If you at least guess, you have a 25% chance that you got that question right. It's better to try than leave it blank. And then marking your books, highlight, write notes. You should have already been doing that as you were working through the program content. So underline your main terms. This is so very helpful. Highlight your key points. And, taking the test electronically online, you're going to have that ability to underline and highlight the questions and the terms within the question. Write effective reminders, such as guidelines in your books. When in your tabular of your CPT or even your ICD-10, you could put the page number of the guideline that particular section goes with, so you know where to go to look for that guideline. For your CPT, highlight those parenthetical guidelines at the beginning of the sections, and that's one of the main things that exam takers miss is those parenthetical guidelines, and that remembering to read those. We always want to read the guidelines. Always, always, always read the guidelines. Even if you think you know the guideline, read the guideline. All right. So we are going to move on now to compliance and regulatory business in the business of medicine. This is going to be covered by 5 questions on the exam, testing your knowledge of compliance and regulations under Medicare's Part A, B, C, and D. Applying coding and payment policy, place of service reporting, fraud and abuse, NCCI edits, your national coverage determinations and local coverage determinations, HIPAA, ABNs, and RVUs are all covered under the business of medicine. So remember, you have about 5 questions on this section. So compliance and regulatory is going to be covered by 3 questions on the exam. Again, like I was saying, testing your knowledge. So 3 to 5 questions is what you will see on the exam for this. So make sure, highlight those guidelines, put notes on those guidelines. Very, very important. ICD-10 CM. You'll have about 5 questions for this section that will require proficiency in diagnoses for all chapters included in your ICD-10 CM, as well as thorough knowledge of those official guidelines for coding and reporting. Mark those guidelines in your ICD-10. Additionally, diagnosis questions will appear in other sections of the exam from those CPT categories. This section of the CPC test will involve 7 questions addressing the ICD-10 CM guidelines for coding and reporting, CPT coding guidelines, and parenthetical notes and modifier use. So let's have an overview for the coding conventions and guidelines for the ICD-10. So at the front of your ICD-10, the conventions for our ICD-10 CM and the official guidelines for coding and reporting are found. The conventions and guidelines instruct our coders in how to read the book and how to properly report and sequence those diagnoses codes. Time should be taken to review both the conventions and the guidelines. You want to make sure that is something you have become familiar with. In section I.A, it lists the conventions for our ICD-10 CM, or section 1B lists the general coding guidelines and instructions on the basic knowledge of using our ICD-10 CM, such as multiple coding for a condition, combination codes, acute and versus chronic conditions, as well as signs and symptoms versus a diagnosis, a definitive diagnosis. So that's something we have to remember. So you want to make sure that you have thoroughly reviewed your official guidelines for coding and reporting. It always goes back to the guidelines. So here we see referencing the guidelines. They are found at the beginning of our ICD-10. Section 1, this is convention, general coding guidelines, and chapter-specific guidelines. So section 1A, it's just going to go through the conventions for our ICD-10 CM. And then with underneath that, we then see 9 categories under that, and it gives our guidelines and instructions for how to use the alphabetic index and tabular list, the format and structure, the use of codes for reporting purposes, our placeholder character, that wonderful X, the use of 7th characters, abbreviation, and then it gives you an alphabetic index abbreviation and your tabular list abbreviation. Very handy, very handy. Punctuation, use of the word and, as well as other, and those wonderful unspecified codes that we do not want to use unless we absolutely have to. The abbreviation NOS. This means not otherwise specified. So this means we lack information to use a more specific code. There is not that information is not in the documentation to allow us to pick a more specific code. So an example of an instruction found in the coding conventions for the use of this abbreviation, it means, like I said, not otherwise specified. This is the equivalent of unspecified. So the use of this code means that, again, we do not have enough information. So when we don't have that, we have a patient that has chronic sinusitis. That directs us to J32.9, which is our chronic sinusitis unspecified, sinusitis chronic NOS. So we would see in our index, it would be a non-essential modifier because it is in parentheses. So it just states for this main term sinusitis, all of these different terms with the sinusitis could use this particular diagnosis code. And then when you go to the tabular and look at the J32.9, gives us that specific, more specific meaning. We see underneath it, chronic, in parentheses, NOS. So that tells us the NOS is appropriate for the J32.9. Parentheses. So these, like I said, they enclose a supplementary word, also known as our non-essential modifiers. And it just means that the documentation doesn't have to state all of this, but we would use one of these codes for that particular type of, like we see here, pneumonia. So if the documentation stated acute, double, migratory, purulent, septic, or unresolved, it would come from the J18.9 category. And if we had anything, any other types of pneumonia, it would go with one of those more specific codes. The word with. This means associated with or due to when it appears in a code title, the alphabetic index, or an instructional note in the tabular list. There is a presumed causal relationship between the main term and the terms listed under the entry with. So in this example, if the provider states the patient had diabetes and stage 5 chronic kidney disease, it is presumed diabetes and chronic kidney disease have a causal relationship and would be coded with E11.22, type 2 diabetes mellitus with diabetic chronic kidney disease. Looking that code up in the tabular, you would find the word use additional code notation to identify the stage of chronic kidney disease. So then we will be required to add another code, which is N18.5, identifying the chronic kidney disease, stage 5. And then referencing our guidelines. Section, a documented reference appears as a section, like we see here in example I-C4A2. The indication that this guideline is found in section I or 1. 1C would be our chapter-specific coding guidelines. IC4 would be chapter 4, endocrine, nutritional, and metabolic diseases. The A indicates diabetes mellitus, and then the 2 indicates the type of diabetes mellitus, not documented. So if we were to go to IC4A2, it is going to give us the chapter-specific guidelines for coding diabetes type 2, not documented, or the type of diabetes that is not documented. So what this means is it's that this, so if the patient, the provider documents the patient has diabetes mellitus, and they do not indicate whether it's type 1 or type 2, then we would code it as type 2. So that is what this guideline is going to state if you were to go look this up in your chapter specific guidelines. Oh, and here it is right here. If the type of diabetes mellitus is not documented in the medical record right here, then the record, the default is E11 point, and then a dash to indicate that it requirement of additional characters, type 2 diabetes mellitus. All right, so on your pre-test questions, question number 1, we have an HIV patient is in her 2nd trimester of pregnancy. She is on antiretroviral medications. Her viral load is virtually undetectable. Her pregnancy is developing normally and without incident. She is 26 weeks pregnant and 26 weeks and 0 days pregnant. What is the ICD-10 codes reported? So you should have been able to determine it to be D, Z34.92 and Z38.26. So let's break this down. In the alphabetic index, we went to pregnancy, complicated by, and then HIV. Then we found HIV positive, long-term use of a therapy or drug, specified NEC, not elsewhere classified, and then weeks of gestation, 26 weeks. So under guideline IC15.A1, chapter 15 codes have sequencing priority over codes from other chapters. Additional codes from other chapters may be used in conjunction with chapter 15 codes to further specify the conditions. And then guideline IC15F indicates HIV infection in pregnancy, childbirth, and puerperium. During pregnancy, childbirth, or puerperium, a patient admitted because of an HIV-related illness should receive a principal diagnosis from subcategory O98.7 with the requirement of additional characters, which is your HIV disease complicating pregnancy, childbirth, and the puerperium, followed by the additional codes for any HIV-related illnesses. And then guideline IC1I for the history of HIV management by medication. If a patient with a documented history of HIV is currently being managed on an antiretroviral medication, we then need to assign code B20 for HIV, and then code Z79.899 for the long-term use of a drug therapy. We then need to identify, and then we need to then make sure we include our Z3A code, which is the weeks of gestation. So that is how we came up with Z34.92 and Z38.26. Actually, the answer should be A. I'm looking at the guidelines. The O98.712, the B20, followed by the additional codes. In double checking my ICD-10, the correct answer for this would be A. It would be O98.712, indicating HIV in pregnancy, complicating pregnancy, followed by B20 to indicate positive HIV, Z79.899 for the use of the antiretroviral medication, and then Z38.26 to indicate that she is 26 weeks and 0 days gestation. So the correct answer for this would be A and not D. So I will make sure I get this updated. All right. Now we move into CPT, surgery guidelines, HCPC level 2, and modifiers. This module is going to take you through everything you need to understand when coding from this section and help you pass your CPC exam. Navigate through this. So our CPT code set includes 3 categories of medical nomenclature with descriptors. We have our category 1, category 2, and category 3. So our category 1 codes are the medical procedures, evaluation and management, radiology, lab, etc. That is our CPT. Category 2 are the codes in our CPT located at the back of the CPT book behind the category 1 codes. These are identified by a letter F at the end. These are optional performance measurement tracking codes assigned to facilitate data by the AMA and CMS regarding quality of care. So for providers, if they are enrolled in the MIPS program, which is a quality Medicare's payment improvement, it's an improvement payment system. So what they are doing is they voluntarily will add these category 2 codes at the end after the CPT codes to indicate if they are doing any type of performance measurement, such as bringing patients in for colorectal screening, or patients with diabetes are coming in and getting their diabetes been managed by doing the A1Cs and other types of medications that's needed to manage. So they're showing that they are taking that step above and providing that quality of care for patients. And that's what this is helping to collect, that quality of care for patients. And then this can lead to improved outcomes for the patients, reduced hospital stays for patients, as well as help providers get better reimbursement. And then category 3 codes are behind our category 2 codes. These are identified by the letter T at the end of the code. They are temporary codes for data collection for the FDA approval regarding new and emerging technology, services, and procedures. All right. So in talking about our CPT, for instructions for the use of the CPT, the second sentence. So there are specific instructions for the use of our CPT book. We have what are called unlisted procedures. These are always located at the very end of a section and end with a 99. We only use an unlisted procedure code when there is no other procedure or a CPT code to describe the service that was provided to the patient. And if you're not finding one in the CPT, you would want to look in your HCPC to see if there is a more suitable code before using, again, an unlisted procedure code. Your parenthetical notes, we always want to make sure that we read our parenthetical notes. When you are looking at the front of the book and it's giving you the CPT, giving you instructions, there is going to be an introduction that indicates the importance of reading those parenthetical instructions regarding those CPT codes. The parenthetical instructions are intended to prevent significant errors, but are not all inclusive. The accuracy, the importance of the accuracy and quality of coding by referring to those parenthetical instructions, related guidelines, as well as there's what they have as an AMA CPT assistant and other resources. But again, we want to make sure we're looking at those parenthetical notes because they provide us with important information. You also want to remember that guidelines are going to appear throughout the CPT, and we should always be aware of them. So our CPT guidelines are going to be referenced in the introduction of each section and subsection of our CPT code book. These guidelines are found throughout the CPT. They are in the introduction of each section of the book and many of the subsections. The guidelines are going to provide specific information as how to apply the codes in the section, such as when to add a service together, report services separately, when to use particular modifiers, and what makes a service complete versus limited, etc. So the guidelines are going to be applicable to the section in which they are being referenced, and they help to define the information necessary for choosing the correct code. You're going to see conventions and iconography as well throughout the CPT, just like we see in our ICD-10 CM. You're going to see indentations, code symbols, iconology, and those parenthetical instructions. The semicolon and the conventional is used as well. The use of the semicolon is going to divide the description of a code into two separate parts. The standalone code, or the common portion of the procedure, is going to be the main portion of the procedure code, and then an indented descriptor is going to be dependent on that preceding standalone code. So if you see a semicolon in front of or underneath and indented above a primary code, that's just going to be more of an extension of the descriptor of that particular procedure or service. So you might see that it says on the shoulder. An add-on code, the plus sign, this just means that add-on code is, this is a child code. So you must report the parent code first before you can report the add-on code. These are always going to be modifier 51 exempt as well. A red bullet. The red bullet is an indication of a new procedure code. A blue triangle indicates a revision to a code. And then opposing triangles indicate a new or revised text other than the procedure descriptor. And I'm not sure why all my little icons have disappeared. A circle with a line through it just means that that code is exempt from modifier 51. Remember, modifier 51 is our multiple procedure modifier. There's also an appendix in your CPT book, the back before the index, that lists all of your modifier 51 exempt codes. A lightning bolt, these are codes for vaccines that are pending FDA approval. And then the hashtag or number symbol, this is a resequenced procedure code, and it is out of numerical order. Our CPT code, remember, has 6 main section titles. We have E&M, or evaluation and management, anesthesia, surgery. Within the surgery, it's going to be broken down by body systems, radiology, pathology and lab, and medicine. All of our CPT codes are 5-digit, remember, such as 1, 2, 3, 4, 5. These are codes that coders are commonly familiar with for reporting medical visits, services, tests, and procedures provided by our physicians and other qualified healthcare personnel. The codes are reviewed and updated annually by the AMA. The codes, new codes begin use on January 1st. It is mandatory to use Category 1 CPT codes for reporting and reimbursement purposes. Section titles have subsections that are going to be divided by an anatomical location, procedure, condition, or descriptor subheading. The subheadings structured by CPT conventions may list alternate suggestions and parenthetical instructions. Before the guideline, there are alternate coding suggestions available, which will help aid the coder in finding a correct diagnosis or procedure code. The guidelines that appear below these suggestions provide valuable information about the correct coding of a procedure in that particular section. They will instruct coders about how to add services together, when to report the items separately, when items are inclusive of other services, what modifiers should be used, etc. Coders should also spend time familiarizing themselves with the guidelines. So here we have an example, surgery section. 10021 through 69990. That's all of the surgery sections. Subsection would be the integumentary system. So that's when it's getting broken down. Within the subsection of the integumentary system, we see a subheading of skin, subcutaneous, and accessory structures. And then the category or procedure service would be a debridement. With underneath that, before you even get to any of the codes, you're going to see alternate coding suggestions. So for dermabrasions, it tells you to go see these particular CPT codes. For nail debridement, for burns, and then for pressure ulcers. So if you are coding for one of those 4 types of procedures, those are the CPT section category and where you would want to go. All kinds of notes always to help you. Our category 2 CPT codes. These are the 5-character alphanumeric codes that end with the letter F. These codes are used for performance measurement and one method for reporting quality to both commercial insurance carriers as well as Medicare for the use of the quality payment program. These codes were previously known as your physician quality reporting system codes. They should not be reported alone. While the reporting of these codes are optional, if they are used, they must be reported with a category 1 CPT code. And then our category 3 codes are our temporary codes. Alphanumeric in structure with a T in the last position, as we see here, 0042T. They can be reported alone without an additional category 1 code. These are used to report emerging technology, services, and procedures. These can be reported. Remember, the instructions for reporting these CPT codes state to report the code that most accurately identifies the service performed. So this may be a temporary code rather than a category 1 code. And then we have our appendices in our CPT. Appendix A lists all of the modifiers that are categorized, modifiers that are going to be applicable to our CPT codes, as well as anesthesia physical status modifiers. CPT level 1 modifiers are also approved for ambulatory surgery center, hospital outpatient use, as well as we know that we can use them along with our HCPCS national modifiers. Appendix B, so all changes to and additions to CPT from the previous year. Appendix C is all clinical E&M examples for different specialties. So it's a good, if you're struggling as you're learning E&M, and those examples can help. Appendix D is all of our add-on codes. E are those that are exempt from modifier 51 use. Appendix F is exempt from the use of modifier 63. This is for procedures performed on infants less than 4 kilograms. Appendix G was removed from our CPT in 2017. Appendix H is an alphabetic index of all the performance measures by clinical condition or topic. It is available actually only on the AMA website. Appendix I is genetic testing code modifiers and it was removed from the CPT in 2013. Appendix J, your electrodiagnostic medicine listing of sensory, motor, and mixed nerves. Wonderful if you're for the neurology coding. Appendix K, all product pending FDA approval. Appendix L is great to use for coding cardiovascular. This is our vascular families. This is based on the assumption that vascular catheterization has a starting point of the aorta. It really helps when it's understanding the branches. Appendix M is a crosswalk of all of our deleted CPT code where you could find the updated or new code that replaced it. Appendix N, a summary of our resequenced CPT codes. Appendix O is for laboratory use. And Appendix F are CPT codes that may be used for synchronous telemedicine services. And these codes are used with real-time telemedicine services when appended with modifier 95. And then we have our HCPCS. These are level 2 codes, permanent national codes that are maintained by CMS, a CMS HCPCS work group. They are responsible for any additions, deletions, and revisions. And it is updated annually, and they go effect on January 1st. All HCPCS codes are 5-character alphanumeric that begin with the alpha letter, such as example A9999. Temporary national codes are also maintained by the CMS HCPCS work group. And again, they are responsible for any additions, deletions, and revisions, and those temporary codes are updated quarterly. For our appendices in our HCPCS, we have a table of drugs, which it lists the names of drugs, dosage, delivery method, and all of the J codes associated with those, as well as our level 2 modifiers, which may be used with some CPT codes as well. Remembering our HCPCS and CPT modifiers are interchangeable with each other. There's a list of abbreviations, your Medicare references, jurisdiction list, as well as a deleted code crosswalk. And remembering each publisher may have different appendices. So a couple of modifiers, 22, increased procedural service, 24, unrelated E&M by the same physician during the post-operative period. So if the patient comes in and sees the provider, say they had a minor surgery done, and they come in because they have a cold or something, you would want to add this 24 modifier to the E&M service. Otherwise, the insurance will bundle it and say it is a part of their post-op, and the provider would not get paid. So you want to make sure that is what that is for. Modifier 25, significant separately identifiable E&M service by the same physician on the same day of a procedure or other service. 57, decision for surgery. This is used when the patient is seen and is being taken to surgery within the next 24 hours. So we want to remember that the global surgery package includes the day before a major surgery, making that visit not billable. However, if the patient is seen emergently and needs surgery quickly, the surgeon can append modifier 57 to indicate this situation and carve out that visit from the global package. 58, staged or related procedure or service by the same physician during the postoperative period. So it's just like it sounds. So sometimes it can be a follow-up procedure that is more extensive than the original procedure. It can also be used to indicate therapy performed following a surgical procedure. An example would be a patient that has a lesion removed that turns out to be malignant without clear margin. The patient is brought back to the operating room 7 days later, and the second more in-depth surgery to remove the cancer is submitted with a modifier 58 to indicate that it is related to the primary or first procedure. Modifier 78 is an unplanned return to the OR or procedure room by the same physician following an initial procedure for a related procedure during the postoperative period. So what it means, it's unplanned. So something happened that's causing the patient to have to go back into surgery. Example, the patient has gastric bypass surgery January. In March, the patient is diagnosed with an incisional hernia at the location of the bypass incision. The patient is then taken back to the OR in March for an incisional hernia repair. The hernia repair is related to the bypass surgery, so we'd want to add a modifier 78 to indicate its use on the hernia repair code. Because again, a lot of times insurance will have a 90-day global period. And so if you're not indicating that something has caused the patient to go back into the OR, the insurance could deny payment. And then 79, unrelated procedure or service by the same physician during the post-op. So this means it's unrelated, but the service or procedure is being done by that same physician or other qualified healthcare professional during the post-op. For example, the patient has to have an open reduction of an ankle fracture in October, and in November the patient has appendicitis and has to have an emergency appendectomy. The appendectomy is unrelated to the ankle fracture repair, and so it would be coded with a modifier 79 to the appendectomy to indicate, again, this is separate from that post-op period and they want to get paid. And then some other surgical modifiers. We have bilateral procedure or 50 modifier, 51 for multiple procedures, 52 for reduced services, and 53 for a discontinued procedure. So reduced services for modifier 52, this is to indicate something within the procedure was partially reduced, it ended early, or it eliminated at the provider's discretion. A discontinued procedure represents a procedure that is terminated due to an extenuating circumstance and or circumstance that threatened the well-being of the patient. We would use this modifier with the procedure code and bill it to the insurance. Modifier 59 is our distinct procedural service. This indicates that something is different from this procedure. So you might use it in this type of instance. For a procedure not normally reported together, a different site or location or organ system, a separate incision or excision, a separate lesion, or a separate injury. And again, the documentation would need to be extremely clear. And then some CMS product provides a subset of modifier 59. So XE, XS, XP, and XU. So we have separate encounter, separate structure, separate practitioner, or unusual non-overlapping service. So if this was a Medicare patient, this is the modifiers we would use instead of modifier 59. Modifier 62 is two surgeons. So two surgeons are working together as a primary surgeon, but are performing a distinct part of a procedure. They dictate an op report of their distinct part, and each will submit the same code and then append modifier 62 to that CPT code. And then modifier 66 is for our surgical teams. These are for those highly complex procedures that require different specialties. The 66 is going to be appended to the procedures coded by the members of the surgical team. So this could be like a multiple organ transplant kind of thing, or think of like when surgeries have been done to separate conjoined twins. They might have a complete surgical team on hand to do the distinct specialties of that particular procedure or body system. Some assistant surgeon modifiers. We have an 80 for assistant surgeon. This is assistant surgeon is present for the entire or a substantial portion of the operation. They report the same surgical procedure with an 80 modifier appended. Whereas a minimum assistant surgeon, they are present that requires a surgeon of an assistant for a short time, minimal assistance. This would be a modifier 81. And then an 82 is for an assistant surgeon when a qualified resident surgeon is not available. So this is used in teaching hospital that employs residents. No resident is available and another surgeon is used. They would append modifier 82. And then our ancillary modifiers. These can be either global, a procedure containing both the technical and professional component. Modifier 26 is the professional component, and the modifier TC is a technical component. So some services are going to be a combination of a professional and technical component. The professional component identifies the work of the physician to perform, read, interpret, or supervise the service, and the technical component identifies the cost associated with owning the equipment, employing the tech, so the supplies, the equipment, the overhead, etc. When services are billed without the modifier, they are considered to be global or inclusive of both technical and professional. To separate out either the technical or professional service, the modifiers TC or 26 are going to be applied to the procedure code. So an example of this could be, where I live, we have a small hospital. So in the past, I have gone there for radiology services. So they take the film there, but they send the film to a physician at a radiology group at another location, and they read it. So the hospital is billing the technical component of that radiology service. And then the physician that's doing the reading of the films and that, they are billing the 26 of the professional component of that radiology service. All right. So that concludes our first portion of the CPC review. Our next section, we will be going over the 10,000 series and this for the integumentary system.